Ambassador of the Department of Financial. Welcome, Sebastian Duengo. How are you?
Good morning. I'm well. How are you?
Good.
Good to see you. Long time no see.
Thank you for your patience.
Yes, good to see you too, Senator Clarkson.
We'd love to hear your thoughts on Section 36 of H703.
Happy to share them. Are we live?
You are. Please introduce yourself.
Okay.
Of this section.
Right. I am Sebastian Arduengo, and I am testifying on behalf of the Department of Financial Regulation with respect to Section 36 of H703. And this section has two subsections that both have a different genesis. So I'll talk about them separately. So subsection A relates to a report that the department did under Act 140 of 2020. And with this report, we were asked to examine opportunities to increase the use of real-time decision support tools embedded in electronic health records to complete prior authorization requests for imaging and pharmacy services. That's a mouthful. And what it really means is what's known in the industry as touchless prior authorization, wherein if there is a service that requires prior authorization, let's say that it's an MRI, when the provider orders the MRI, the electronic health record system used by the provider is smart enough to know that this service requires prior authorization, and then automatically sends all of the clinical information to the insurer to do that prior authorization, and it is either denied with information about what clinical information is needed for approval, or approved automatically with no further input needed from the provider. That's kind of the dream as far as using electronic health records to support the prior authorization process right now. Unfortunately, the reality is that every health plan more or less has its own bespoke prior authorization system. And these systems work with some provider electronic health record systems, but not all. And a good example of this is the system that Blue Cross Blue Shield of Vermont uses. It's called AIM. It's made by a company called AIM Specialty Health. And it is an online provider portal through which providers can electronically submit prior authorization requests. This requires the provider to log onto the portal and tell Blue Cross what service the provider wants to order for their patient, and then attach all of the documentation to support that request. It's not as time consuming as doing it the old way, which would be the provider literally faxing the prior authorization request form and supporting documentation to Blue Cross, but it's still cumbersome for the provider to do. In 2022, where supported, Blue Cross Blue Shield's in-network providers are going to have access to an API or application programming interface that integrates with systems like Epic to allow for touchless prior auth. And that's great, but it's still only one insurer's bespoke prior authorization software that works with the EHR used by some providers. And at the end of the day, this really boils down to an IT problem in which health plans all have their own systems and providers all have their own systems, and they're not really designed to talk to each other outside of the very limited context of the provider submits a claim to the insurer for reimbursement. So the key to solving this problem is to have a health data interoperability standard where if an insurer needs data from a provider for whatever reason, and especially in the prior authorization context, their systems know how to pull data from the provider's systems. And we looked into this in a couple of different ways in our report. One of the first things we did was to engage with Vital, or the Vermont Information Technology leaders, and they function as the state's health information exchange. And what it's supposed to do is let providers exchange health information to each other without needing to fax over records or anything like that. So lots of providers already submit clinical information to Vital. And we looked into the possibility of leveraging that information to support prior auth requests. And we met with the vendors used by some of the insurers and with Vital to see what could be done to make that happen. And although Vital couldn't be used to support touchless prior authorization, largely because Vital doesn't collect future appointment data from providers, and adding that data element would require a lot of work on the part of both Vital and providers and would take a long time to implement. There is data in the health information exchange that could be used to support prior authorization requests. We also looked at the possibility of having our own data interoperability standard and requiring health insurers to adopt that standard to communicate with provider electronic health record system. There is a standard out there right now called the Da Vinci project that's still being implemented, but the concern raised by both providers and insurers is that there is a federal regulation that is in the pipe that would require all providers and insurers in the country to adopt a single data interoperability standard. So our thinking after looking into the proposed rule from the federal government and hearing from the stakeholders was that it would not be ideal for Vermont to adopt its own data interoperability standard and then have the federal government come in and require something else. So we think the path forward for touchless prior authorizations, no matter what system the insurer or the provider is using, is to hold off for now and wait for the final interoperability rule. And once that is fully adopted, that will make it much easier for providers and insurers to more tightly integrate their systems.
So can I interrupt, Sebastian?
Yes.
So this exploring of the feasibility is a continuation of a legislative request from the past, and it kicks it down the road a year and a half, waiting on the federal government for more critical information, or to somehow align what you're going to suggest with what they allow and suggest. Is that the long and the short of it? And then the second part of my question, what does this have to do with workforce?
Yeah, so the long and the short of it is that until the federal interoperability rule comes out, we want to work with Vital to see if insurers can pull whatever they can from Vital in lieu of providers logging on to AIM or EviCore or whatever other vendors used by other insurers to submit that information. And even though it wouldn't be touchless, we want to try and reduce the work burden on providers to support prior auth requests as much as we can. This doesn't really have a bearing on the workforce, except insofar as, like I said earlier, reducing that burden of providing the documentation to support a prior auth request to the extent that we can under state law.
Reducing the number of jobs in the state. I'm just teasing.
No, it's not reducing number of jobs. This reduces work burdens.
So
yes, I think to clarify, what the idea would be to decrease the amount of time that providers and clinicians are spending sending in materials for prior authorization, and really increase the amount of time that they have available to see patients.
So this is a request of the department, and you need this to be able to order Vital to play in the sandbox, so to speak.
Right, I think so.
Right.
Any other questions for Sebastian?
No, it's nice to see where you've landed. I actually I understood your beginning and your end, and a lot of the in-between I didn't fully understand, but I get your request despite that. And it's great to see that you're at DFR.
Yes, thank you, Senator Clarkson. I think DFR is a great place to work, and I'm very glad to have landed here. And if you do have questions about at the middle of my testimony, I'm happy to field those.
No, it just.
I think we get it.
We get it. It's
okay.
just we get it. I got the bookends.
Okay. Well, thank you very much. If we have any further questions, we'll get back to you on this. You have any opposition to this as far as you're aware?
No, I think there's a lot of interest from all of the stakeholders, from providers, from insurers, and from Vital to use any health information we have to the fullest extent that we can.
Appreciate it, and we'll get back to you if you have any questions.
Yeah,
thank you for being here.
At some point, I'd love to know how it ended up in this bill and not in a bill elsewhere in Jenny's committee, but I guess that's for another day.
Thank you.
Yes, I would direct that question to Legislative Counsel.
Okay, great. Thanks, Sebastian. It's wonderful to see you.
Thank you.
Thank you, Senator Clarkson. Great to see you too.
So we're going to move on to Al Cormier. Welcome, Mr. Cormier. There's some provisions in 8703 that have to deal with the Department of Corrections. So we'd like you to direct us to those sections, the page numbers and the section numbers, and give us some background after you introduce yourself on what these sections are about, what's being asked for, and your position on them.
Great, thank you. Good morning. Alan Cormier, Chief of Operations for the Department of Corrections, here to provide testimony on sections 6, 7, 8, and 9 in H703, starting on page 11. The first section is in relation to individuals, incarcerated individuals in workforce development, a pilot program. I'll start by saying that we understand that this funding is not in the governor's budget bill, and therefore it's hard for us to support the funding without it being there. But we do support the initiatives outlined in this legislation. That money and the collaboration and consultation with the Department of Labor, this is a project that we've been working on. We have a pretty robust relationship with DOL now, and have been working to transition from a business model in our correctional industries to a more robust vocational training model. So we do support the initiatives and the programs as written in the legislation. The second part of that, the $300,000 for the reentry based pilot program at Chittenden Regional Correctional Facility. Again, supportive of that initiative. We work with a lot of community stakeholders now, the Vermont Network and Vermont Works for Women, supporting reentry services as we move forward with the creation of a new women's correctional facility, which is being discussed with HCI and others. The establishment of those types of programs are going to be paramount in our success of a women's reentry facility, a dedicated reentry facility. So again, we do support that initiative. We do support the requirement for that report. That report is something we are working on now and intend to continue to work on at the end of the legislative session to really focus on how we are going to get to those next steps in these proposals here regarding the expansion of employment readiness, reentry readiness, basically pathways for success for these women getting out, as well as the the vocational training component with DOL for the rest of our incarcerated population.
So if I could interrupt for a second, on the 300,000, that's also not in the governor's requested budget.
Correct.
And these services that the $300,000 focus on, are they not being done now at all, or is this to enhance existing services in this regard?
That funding would enhance and improve the existing services now.
And is there any specific pot of money or bucket of money that provides for these services presently, or is it just within DOC's general budget?
Yeah, we do have funding allocated for this with contracts for the women's services programs at Chittenden. That is money that we distribute through the grant process. I have Kristen Lawson here, our financial director, that can speak more to that funding source if needed.
And the last question I have is on 1A. It says the funds shall not be allocated from amounts budgeted for justice reinvestment to initiatives. So that sets up a question for me is, are these things like the 270,000, 100,000, are they in some ways fundable through justice reinvestment if you choose to make them priorities presently, but you just don't want to move those funds?
Well, we have projects outlined already for the use of the justice reinvestment funding, and not wanting to take away from what's already established to utilize those funds.
Okay.
which is included in the governor's budget.
Can you just say a few words? I think of the the correction population. I do think that they're not only a challenge to reemploy, but very sort of a fertile ground for employment. And I know about the furlough problems, housing and stuff like that. But do you and yours, I don't know if you're the right person to ask, but do you in your situation, feel that there's great potential for this money to actually get people jobs and things?
I think there is, and you bring up some great points around the challenges with finding employment for this population as they reenter the community. Vermont has a 2.5% unemployment rate. There's something like 40,000 jobs available right now. So it's not the jobs that are the problem. It's getting these folks trained and ready for the jobs. So these programs will enhance those job skills, those entry-level job skills, and enhance job skills that are above that entry-level position, potentially, electricians, welders, that kind of thing. Jobs that are in high demand that we can hopefully get these folks involved with. We are working with AOT on some CDL licensing certifications. That's a program we have going now. AOT, DOL, and DOC have worked collaboratively in the last several months to try to get these folks ready.
Sarah Clarkson.
Al, it's good to see you. Nice to also see you in a different committee. And
Yes,
this
thank
is
you.
an important one for us to see you in. I think when people were incarcerated for longer, we had great training programs. I remember in the past, and now that our turnover rate generally for the general incarcerated population is shorter, we have shorter periods of time to train people substantively in skills. But I well remember the Vermont Works for Women program at the Windsor prison that turned out people who were trained in electric, plumbing, general contracting, and the carpentry skills.
Yeah.
I wish we had the money to do a longitudinal study on how they've done, because they all left with real skills that they could use right away and product they were proud of. They were that, when we dedicated those houses in Springfield, they were proud of that work. And
Very proud.
Reclaiming, to me, this is a bunch of reinventing the wheel, because we did a lot of this work before. So it's sort of sad that we have to have a mobile unit that's going to go from facility to facility to train people, and not have embedded in each facility a first-class CTE center. So I guess to me this is great, but a little bit of a Band-Aid. I'd rather see us spend a lot more on developing CTE centers in every facility. And
Yeah.
I guess that's one of my questions for you is, does the corrections have a broader, longer, bigger vision for how to train people who are there for less time? Is this the answer, or are you actually investing in career training in the facilities that's more substantive and more ongoing and more embedded?
Great point on the past, and to some extent we are reinventing the wheel, going back to what we have seen in the past.
Now this is back to the future.
Back to the future, exactly. And one benefit we have there is we've just hired a new director of women's services, Kathy Aston-Borski, who was the assistant superintendent at Windsor when those programs were going on. So she has the experience there, which we will need. So is this the answer? I think it's part of the answer. It's a piece of the answer for sure. As we continue to work towards the next phase of our feasibility study on new correctional facilities being built in Vermont, outside of just the women's facility, part of those proposals do include technical training centers, both for the women's facility and for potentially a male facility as well. We have great space in Newport that we can utilize for vocational training as well. And back to our partnerships with some of the community CTEs already, those conversations are happening around the potential for mobile labs. And what that does, it's actually a cost savings because those labs can go facility to facility
Yeah.
and they can rotate for that population that is turning over. So in essence, it is a benefit to us to be able to rotate through without having to spend the money on just one particular program in a vocational center. Be able to move that around through those community partnerships.
Well,
So we are looking.
yeah, and and I know your partnership with DOL is ever more expanding,
Yes.
right? I mean,
Yes, that's a solid partnership.
thank goodness.
So as I move on to the study language on section 8 and 9, I guess and the legislative intent language in section 7, I was reading it thinking that this was all about inmates and people getting out of about correctional officers. So I
Yeah.
assume you're having a recruitment problem right now in the state for correctional officers.
Yeah, so moving on to section 7, we have a recruitment and retention issue, much like every other agency and department in state government. Corrections in general across the nation is facing shortfalls of correctional officers and shortages. We have improved and we continue to improve on our recruitment and retention efforts. We have in our Office of Professional Standards and Compliance, we have recruitment officers that are working that. We've expanded our recruitment efforts at each of our facilities, utilizing social media, recruitment videos, expanding our use of Indeed. That has brought in more applications. Excuse me?
It's great to hear you're using Indeed because it would be very helpful.
It is, and we found unfortunately found a snafu with the success factor system that we've been able to work around. When we started using that, Indeed has the applications and the resumes already uploaded, right? So somebody should just be able to push a button and it sends it. Well, unfortunately with success factors, it sends them to success factors and asks them to resubmit everything piece by piece again. What we saw in January was we had 20,000 clicks on correctional officer positions. Of those 20,000 clicks, 200 people went to success factors. Of those 200, only 10 went forward with an actual application. So we've eliminated that component, and when the application is submitted, it goes right to the business manager at the selected facility, and they're immediately reaching out. So we have seen success in kind of bypassing the system and being able to reach out directly in a timely manner. We have 16 correctional officers graduating tomorrow from our academy, and we have 9 scheduled for the next academy in May while recruiting efforts are still ongoing. So I would hope to see another 8 to 10 for our next class as well.
And how many do you need?
Close to 100.
That's the problem.
That's the problem.
Yeah.
So as I read section 9, it's another report. I guess there was some funds put in for various retention and recruitment efforts in the Budget Adjustment Act. This is just looking just for a report back as to how effective those funds have been, and your name in a couple of places. It's from section 68 of that bill, and also a requirement for recommendations for additional funds in next year's Budget Adjustment Act to address the ongoing recruitment retention challenges at Department of Correction facilities.
Yes.
So you're all good with that language?
Well, this is an onerous task, I'll say. I mean, this one piece of legislation, these 4 sections are requiring 3 very robust reports in a 6-month time frame. But we have a number of other very robust reports due from other legislative committees. It's a huge workload, and we're looking at these items. Unfortunately, we don't have a lot of data to point to the root cause of our retention issues. We know the recruitment issues is because of the low unemployment rate. The retention issues we're working on in-house. We're working with a consulting firm right now, the Moss Group, where we are focusing on training our first line supervisors, which we find in our exit interviews is a big issue. People don't leave a bad job. They tend to leave a bad supervisor. So focusing on that supervisory level and that mid-level management around retention efforts, more of a mentoring program for the staff that we have in our facilities. What we found in some of our surveys with staff do not dislike their job. They enjoy their jobs. They just, because of the shortage, they end up leaving because of the overtime that those vacancies create. It's not the work, it's the overtime.
So Al, corrections, you know better than I, has suffered from terrible low morale and a real culture challenge. What progress, because I think that's obviously key. Word of mouth is the reason people don't apply also, and that culture is tough and insidious and hard to change, because you've been working on it for a while. What progress are you making on that? And because that seems to me like the number one thing that's got to change for you to have people who are happy in their jobs and want to stay, and to your recruitment, because people check you out as much as you check them out.
Right. Very, very true. I started in 1994 working 12 and 16-hour days myself. So overtime has always been an issue. Recruitment has always been an issue. It's a tough job, and it's not a job for everybody. But I think what has been the biggest issue for us is in the last 2 years is COVID. That has impacted people's ability to socialize, to spend time together in the break rooms. While we have probably the safest correctional system in the country, we are the only correctional system in the country to not have a death of an incarcerated individual or a staff member in COVID. Our protocols work, but they also put a wedge between the socialization of staff being able to hang out in a break room, or the social distancing requirements and people not wanting to get together after work and build those relationships. We are working towards reopening our services. All of our facilities are back to visiting. Programming is coming back in. Volunteer services are coming back in. Commissioner Demel is doing an amazing job with messaging and communication with staff. Those are things that are helping us now. We're coming out of COVID. We're reopening. People are able to socialize again. We're getting back to a sense of normalcy inside of our correctional facility. Not to say that we didn't have recruitment issues before. We did. But I think as we move out of that and people are more able to move around and have those interactions with their peers, that will certainly improve the culture of our facilities. Some of the training opportunities that we're providing, that's what staff have asked for. They're asking for training. They're asking for more training. They're asking for professional development. Those are all things that we're able to provide and
watch it.
Work with our staff on. So I see those as improvements.
Okay.
Cool. Can I just revisit this report concern? So Al, I hear your report concern. Is there a report here that we could do differently that wasn't as big a burden? Just
Just let me interject, the big report is directed to the Agency of Human Services Secretary, so it may not necessarily be the department. It's in
It's
consultation.
in consultation, both of them are in consultation.
I understand.
Yeah.
But
Yeah, okay.
I mean, if there's a pressure,
It's on the
still,
secretary.
it's on the secretary to recognize that.
Yeah, I mean, we can certainly provide data points and information that isn't as robust, but we'll get you the information you need. Part of my concern on this one too is this inadvertently puts a lot of workload on Maine, New Hampshire, New York, Massachusetts, and us having to go to them to find the information that's requested. I can tell you they're in the same boat. And I know that Massachusetts and New Hampshire actually had to bring in National Guard troops several months ago to staff their facilities because the staffing was so bad. We have.
Our staff too, as I think I've heard.
What's that?
They've been raiding, Massachusetts in particular has been raiding our staff, particularly.
Yes. Well, I think we're kind of rating everybody's staff.
Yeah.
We all are. I mean, we've done a lot of recruitment out of New York where there's been some correctional facilities on the border that have closed.
Al, I would suggest if you want to haircut this study a little bit, you send us a memo and explain what you'd rather see the study say that you think can get to the same information the legislature.
Okay.
needs, but focus on key things and we would consider that.
Yeah, we can certainly do that.
Is there anything else you'd like to say? Because I'd like to move us along to our next witnesses if possible. I appreciate you being here.
Yeah, no, thank you. I think that's it for today. Thank you very much.
Thank you.
Thanks.
Okay.
Thank you, Al. Good to see you.
Yes, you too, Senator Clarkson.
So I definitely want to spend 5 minutes at the end of the committee on our bill tomorrow. So we have 25 minutes and we have
Right here.
We have UVM Office of Engagement and Gus Seelig on, and then we have okay. So I'm gonna, Gus, if you don't mind, because you're around a lot and we'll take you by Zoom, I want to make sure we hear from AHAC first. And that's you, right?
Yes.
Okay. Why don't you take a seat? So Elizabeth, it's nice to meet you. We're picking up in our testimony that there's a little bit of angst in terms of should be running some scholarship loan scholarship programs and loan payoff programs that are, frankly, as I sense it, some of these are run by you already, but within this bill, now the second loan program is now being designated to PSAC. Am I getting that correct?
Yes, that's my understanding from the version of the bill that I have reviewed.
Okay, why don't you introduce
So,
yourself?
hi, thank you for inviting me.
Okay.
My name is Liz Cody, and I'm the director of the UVM Office of Primary Care and Area Health Education Centers Program, AHAC. And I have been involved in these programs since 2005. And our agency or organization has administered educational loan repayment for healthcare professionals on behalf of the state of Vermont since 1997. So we are an organization that is 100% dedicated to health workforce development. And what struck me from my review of this bill is that we're completely absent in the bill.
Yes.
Like completely.
Right.
And
Just
so-
before you go on, do you work for the medical center for the university or?
I'm employed by the University of Vermont, the Lerner College of Medicine. And within the College of Medicine, there is an Office of Primary Care. And then we write a lot of grants and receive funding from the state and some federal grants and other organizations to form the AHEC program, which is the Office of Primary Care's largest program, grant-funded program. And it's an extension service program. We have 2 regional centers in the state, one in St. Johnsbury, one in
So you're
Springfield.
not just working for the University of Vermont, you're working statewide.
Correct. And so the 2 regional offices are independent 501c3 organizations. And they're set up that way on purpose, even though we offer extension services, like we think about agricultural extension or manufacturing extension services like Vermont Tech. The AHEC program is a federally funded program, and it's in almost every state. And the regional centers are required to be separate from the university. And that's so that the local voice, the community voice, is being listened to and heard, and it is influencing programming, and that we're not pressing down on the communities. So the 3 organizations, the office at UVM, the AHEC office at UVM, and then the Northern Vermont AHEC in St. Johnsbury, and the Southern Vermont AHEC in Springfield, together we are dedicated to health workforce development and offering programming and support statewide.
But you run the whole schmagag.
I'm the director, so I collaborate with our partners.
So when you
Together.
when you started out with this, because you're in the Office of Primary Care, maybe I'm interpreting primary care incorrectly, we're mostly focusing on recruitment and retention of doctors.
That's a great question, thank you. So the AHEC program is health workforce broadly.
Okay.
A lot of the initiatives that we do focus on at UVM are, because I work for the College of Medicine, are focused on the medical students and the physician workforce. But we have programming for dentists, programming for nurses. We offer continuing education to all health disciplines and specialties and professions. So it's very broad, and it's not only medical student or physician related.
How much money do you control in the course of the year with your loan programs, whatever?
Roughly $4 million. Pieced together, it's a real patchwork of various grants and different sources, fundraising as well.
And how many staff do you have? The office of, is it called the Office of Primary Care, or are you a narrow piece of that Office of Primary Care?
Office of Primary Care and AHEC program.
Okay.
So the regional centers have roughly 5 or 6 FTEs, and our office has about 8 FTEs, plus we work with faculty at UVM College of Medicine and purchase percents of their time so that we have the clinical expertise to guide our programs. There's an associate dean for primary care, Charles McLean, and so he's the overarching leader, clinical leader of our programs.
So did you testify on this bill?
No, this is the first time I have been asked, and I only
Which is a puzzle.
recently learned of the bill. I've been nose to the grind on actual program delivery, and so this was brought to my attention recently after BSAC gave testimony. And so then when I read,
And if you saw their testimony, they actually suggested that we speak to you.
Yes, that's what led us to.
They didn't know why they're being given money.
right, so when we have
Yeah, no, so I'm just curious, because this healthcare community that you help oversee is in part managed by the OPR. The nurses have their boards of directors in OPR. It's a puzzlement to me how, and doctors have the Vermont Medical Society. There are all these different organizations sort of hovering over the healthcare industry. It's sort of a lot of, well, I'm restraining myself again. So I'm just curious how you've ended up with this specific little carve out of loan repayment, or do you oversee other financial aspects of like other tuition programs and other upskilling work for, not necessarily for doctors so much, but for other pieces of healthcare?
Yeah, so the state of Vermont was one of the first states to start an educational loan repayment program back in maybe 1994, 1995, and it was run by the health department. And the health department, I think after experiencing the undertaking, decided to outsource that work through a grant and work with the newly established AHAC program in the state at the time. And so the work transferred from the health department to AHAC in 1997. And the decision making that went into that, I don't know. It is before my time.
But is that what you primarily oversee for the healthcare financial world is, or do you also do tuition and other?
Not tuition, other things. So we work to be a full spectrum health workforce development organization. So we have early pipeline activities starting with 5th graders. We go through high school and we work with undergraduate students, then health profession students as we move along that pipeline. And some of the materials that I gave you have visuals that lead you through that workforce development pipeline.
And so you work with CTE centers?
We do work with them some. I think that there is a lot of opportunity there. We work with high schools, middle schools, after school programs for the middle school, the 5th through 8th grade group. And then undergraduates, we work primarily with UVM undergraduates, pre-health, pre-med. And we are in discussions to strengthen our relationships with the state college system.
Good. Yes.
And so as we continue along that pipeline, the health profession students, such as medical students, we have a lot of programming. Some of our federal funding requires certain programming. Your packet includes information about the Vermont AHEC Scholars Program, where we deliver 160 extracurricular hours to medical students who enroll in the program about topics like diversity, equity, inclusion, cultural competence, behavioral health and primary care integration, oral health and medical integration, social determinants of health, things where there are gaps in medical school curriculum that you would find at any medical school. We attempt to fill those and help the medical students understand Vermont's workforce landscapes, Vermont's workforce needs, and we use that as an early recruitment tool. And so as we continue on that pipeline, we've collaborated with BSAC on the Vermont Medical Student Incentive Scholarship / Loan Forgiveness Program, which you heard about. And that's, I feel like, is a beautiful collaboration or partnership program that I'd like to talk about a little bit more, because I think that is a good direction to be going for some of these workforce development initiatives. And so we link that to the work we're doing with the medical students. So all of these programs link. They're not just separate things or a scattershot approach to workforce development. And we continue on that pipeline, and that's when we get to, after the scholarship piece, that's when we get to loan repayment, educational loan repayment.
So that's, when I look at your chart here, that seems to be the most relevant portion to this bill that you presently do, right?
Yes, but I would say what the bill is trying to accomplish, everything that AHEC does is relevant to this bill.
Now, I know the new initiatives or section by section analysis of the bill, that's where the flag goes up. So something you already do, more millions more has been put into that's now suggested to go to the center.
We don't need to reinvent the wheel with you. You're already doing it.
And the reason why we do it rather than BSAC is because the way the program is structured, it's not simply just writing checks to pay somebody's loans. It's about understanding the workforce makeup, the workforce shortages, the workforce needs. It's the ability to longitudinally track the workforce and to understand what are the ups and downs in different specialties, different practices, what counties have the greatest shortages, so that we're dedicating the limited resources to those greatest shortages. And an organization outside of healthcare just would not have that kind of information or data unless they started from scratch to create it.
So how much money on an annual basis do you have to pay off loans of people with medical professions?
So in 2021, we dispersed about 1.7 million in educational loan repayment.
And where do you get that money from?
So that money is from the state, from the federal, the state educational loan repayment program that comes to us, the federal state loan repayment program that we administer, and then we fundraise from foundations and also the employers, because we've structured the program so that employers have skin in the game. They're contributing as well. We raise those dollars, we collect those dollars from employers to create matching funds. We pool them together. We disperse them in one contract, one pooled award. It also allows the awards to be large enough to make a difference in anybody's decision-making, because that's key. If the award is too small, it's not going to influence anybody's decision. We execute the legal contract, service contract for the 12-month or 24-month period in exchange for the award. And then we verify all educational debt. It's not just self-reported. We have documentation that supports how much debt, educational debt, and then the disbursements we make go directly to the lenders. So 100% of the funds that we disperse reduce educational debt. No dollars go to individuals.
It has to be educational debt.
It has to be educational debt from a verifiable educational lending program, federal or private. It cannot be credit card, it cannot be mortgages, it can't be debt for other family members.
And it doesn't have to be medical education debt.
It's any educational debt, undergraduate debt, graduate programs, health profession programs, whatever the combined educational debt is, we factor.
And you said 12 and 24 months, I assume part of the debt relief is a commitment for the student to work in the bond for a certain period of time.
Yeah, so the scholarship program, the incentive scholarship program and loan forgiveness that you heard about the VSAC, that's for current students for a future service obligation. So we give you this, and in the future, you're going to deliver a service obligation. And for that particular program, if they do deliver the service obligation, the loan is forgiven. That's why it's loan forgiveness, or it remains an incentive scholarship. If they don't deliver that service obligation in the future, they have to pay it back. So it's for current students. Educational loan repayment is for current practicing, licensed, ready to work professionals. They're done all of their training. They're able to work, right off the bat. And the commitment is that they lock into providing whatever kind of health profession service they are at a specific site in Vermont for a 12-month period. Typically, the federal program requires 24-month period.
They do,
but
they have to stay in one place for 24 months.
They do.
Oh, that's good.
It is, but it isn't. We experimented with that, and we learned that it actually has more pitfalls than benefits.
Well,
So
because this bill does some places require 2 years.
yeah, the lock-in period. So what we saw there is just an increase in defaults or breach of contract. It did not actually work the way we thought it would, and created a whole bunch of other problems. But we have over these 20 plus years of administering these programs, we've experimented, and we learn from one year and adjust to the next year. We learn from other programs. We learn from the federal programs. And so there's a lot of kind of adjusting and experimenting to try to figure out what is the most effective program. In all of these programs, from our 5th grader programs all the way up to our current practicing workforce, requires longitudinal tracking so that you can decide and figure out and evaluate, did this make any difference? What seems to be most effective? What sounded good but didn't really work the way we thought? That's the kind of thing that we do. And because most of these programs do require that longitudinal commitment, you're not going to necessarily see benefit from most workforce programs tomorrow. It takes time.
So most of the people who are looking for loan forgiveness, are they about to enter a new job? Are they changing jobs, or are they in the middle of a job that they've been working for 5 years and just all of a sudden realize I can get some of that money forgiven here?
So loan repayment.
Because you don't do loan forgiveness.
Loan forgiveness, we participate with VSAC.
Right.
But we collaborate with them on the medical student loan forgiveness program. With loan repayment, it's really a mix. We have, when we offer the program is there are 3 ways to have an applicant. One could be a recruitment application, which an employer puts in saying, we have a vacancy and we're trying to recruit and we're hoping to fill it in the next year. And if they're awarded funds, they would have those dollars as part of the package or a carrot to offer to candidates. So that's a recruitment award. We also have for physicians, there's a job seeker, and for dentists as well, a job seeker category. That's somebody who's in their final year of residency training, and they're looking for a job, but they don't know where they're going to work. And so they could receive an award if they work in a certain county or in the state, any place, depending upon the situation. So that's how a job seeker could get an award. And the majority are retention awards. They're individuals who are currently in the workforce, and we're trying to lock them in to stabilize the workforce in a specific practice or community or county. So there's a range of the type of applicants.
So is that latter group somebody that comes to your attention because the employer says this person's making noise about leaving?
Yes, so all of our programs are done in partnership with employers. So an applicant would apply, but they also have the employer is also part of the application process and is part of the co-signer of the service obligation, so that it's an agreement between the individual who's going to receive the direct benefit of loan repayment and their employer. And so they're in it together. And that component, plus the honing up and having some employer match in the mix, helps the employer sort through, is this somebody that we really need to retain? Is this somebody at risk? And they put that forward in the application process.
So what's the size of the grants? How do you determine that?
Yeah, so it all depends on funding, but also the number of applicants and what we have to work with in a given year. The minimum award is 10,000 plus match money. So the minimum award would be a 20,000 total award, and the maximum is 40 for 1 year.
Wow, that's a lot for 1 year. And can they apply multiple years?
They can apply up to 6 years. No, they can receive up to 6 years and apply more on.
So does it go from LNAs all the way up to medical specialists?
LPNs, so we don't have a program for LNAs currently, but LPNs, RNs, MDs, PAs, APRNs, dentists, and then in the medical specialties, it's primary care specialties, geriatrics, psychiatry, behavioral health, substance use disorder.
So because you're a primary care center, you would perform with this to an oncologist or something?
Yeah, so most of our work is dedicated to primary care. The reason there's an Office of Primary Care at UVM was per legislative recommendation in 1993. And so, so that there would be a focus and champion on primary care issues. So that's how we started. And that has been our focus because that is the focus of most of the grant funds that we receive. However, we do also have a physician placement service, a physician placement specialist, who works with all UVM College of Medicine graduates who are off in residency all across the country. And when they're in their final year of residency, any specialty, we work to help make sure they know about the Vermont vacancies in that particular specialty. And we also work with the UVM Medical Center residents who are in their final year of residency to do the same. So we're trying to match make, and it's any specialty. And that's at no cost, no fee to the employers, no fee to the individual physician. We do that through grant funding from the state, or partial grant funding and partial College of Medicine funding to offer that service. But each year we directly place 13 to 19 physicians in the state of Vermont,
So
any specialty.
how many, if you're giving grants in the neighborhood of 20 to 40,000, have a budget of 1.6 million, roughly how many grants or how many loan repayments are you making a year?
So I'm going to say somewhere around 90 off the top of my head. So we had last year 167 applications that came in for processing. Some of them were ineligible.
167.
Yes, and all
Right.
professions. And within that, the dental applicant pool is pretty small, and somewhere between annually 70 and 90% of the eligible applicants receive an award. For
70% what?
70 to 90% receive an award for the dental applicants. For the medical program, which is physicians, nurse practitioners, PAs, an average of 52% of the applicant pool receives an award. And for nursing, it probably is like 80% of the pool. But there are also eligibility requirements so that we narrow the pool, because we don't want 5,000 applications based on the funding that we have to give out. We don't have the capacity to process those. So with more money and more capacity, eligibility parameters could be opened up.
What are those eligible?
Yeah.
Needs tested? Is it needs tested?
No, it's based on workforce shortage. It's based on federal formulas of health professional shortage areas or medically underserved areas, medically underserved professions. So it aligns with some of the criteria that the federal programs use. And there's a key piece in this. As the state sanctioned educational loan repayment program, the one that is administered by AHEC, we have to use workforce needs, workforce shortages as the primary eligibility, because the Affordable Care Act allows that program to offer these awards as income tax exempt transactions. Before the Affordable Care Act, when we administered these programs, they were taxable. And it reduced the amount, the value of the award as far as reducing educational debt. Since 2011, and they also made it retroactive 1 year just to make it complicated for us. They're income tax exempt transactions. So again, every dollar invested does reduce educational debt. But if we veer off from focusing on workforce shortages, that becomes a problem in IRS related components, because we have to ensure that these are not just employment bonuses or thank you awards, appreciation awards.
Right.
They have to fulfill a documented need. And so we federal data, state collected data, our own collected data to document needs and awarding. And all of our award eligibility for each of the programs that we administer is posted on our website.
So is your money, the federal and state dollars, they sort of become fungible? People don't apply for one state or federal. You basically use the federal guidelines of shortage so that you may, as a nurse, for instance, get an award if your job is in Burlington, but you might not get an award if it's in Stowe, if there's no shortage there or something like that. Is that the eligibility requirement kicks in?
Yeah, so we do use those things as the primary guide, but we also use the information that we have that is more real time.
Okay.
And so if we know that there have been, the data might not indicate there's a shortage, but or people just left or a practice just closed in that particular area, we know that and we can factor that because we can document it. And so that's again an example of where you have to kind of be ears to the ground and in the community and know what's happening in the industry and in the sector in order to administer these programs most effectively.
So I think this is my starting question, just to reiterate. How much money did you get from the state of Vermont last year?
For educational loan repayment, we received $667,111.
And has that been an ongoing appropriation for many years around that number?
It has been flat funded for many years. We peaked in 2009, I believe, and it might have been 1.8 million.
Okay.
There were cuts and rescissions.
And was it broadened scope of the people you were required to serve, or has it always been the wide range that you're able to serve with this?
The current program, it was more like the current program. Nurse faculty were involved at one point, and then the funding for that program was eliminated by the state. So then that program went away. But it's been this kind of broad program that currently exists for a long time. You know, there are other programs that are popping up that are not being administered the same way, that we're not in the mix on. And I think that's a little bit worrisome because you start to have different parameters and different evaluations, and it's hard to know what's really happening as we look at workforce development as a whole.
So would you be able to provide us with a one-page memo of these other programs that are doing similar things to what you're doing? I think you're sensing that that might not be the most efficient way to do things. You know, we're having a real hard time,
Sure.
not just in your area, but it seems in every area, knowing what other programs are working in parallel in terms of workforce financial help.
I can try based on what I know.
That's fine.
So in addition to the 667,000, I do want to point out that those dollars have been, when we receive those dollars, 100% of those dollars has gone out as an award. We have never taken for over 20 years an indirect or direct administrative fee for those. And that's becoming really difficult to sustain. So paying for administration costs of these labor-intensive programs that require longitudinal tracking and documentation is something that needs to be addressed. AHEC, for the statewide program that we offer to middle school, high school, and undergraduate students, and all of the continuing education programs that we offer, we received $500,000 from the state for that statewide program that's shared by the 3 organizations equally. And that has been flat funded since 2006. And related to the educational loan repayment, you asked how much we've had over the years. In many years, the program gets zeroed out in the state budget, and then we have to come and just be happy getting level funding back. And so we do need to really look at the investments in workforce. I read everything, it's a crisis. We've got to do something. I feel like the way we have been operating state policy and such, we're perpetuating the crisis. We're not looking at these things longitudinally. We're trying to just have a quick response for tomorrow. We need to back up. We need to start to focus on the early pipeline, the youth, 5th graders, the high school students. We need to sustain and support and make sure we have a strong educational loan payment program and scholarship program. Those things are needed too. But if we continue to ignore the early pipeline, we're always going to be in this situation of trying to fix something like right off the bat for tomorrow. And it's impossible.
Right. I don't think we're ignoring the early pipeline. I think we making major investments in career and technical education. And I don't see anything here before middle school, but we're pretty focused on middle school up.
Okay, is there more that you'd like to say, because we're run out of time?
Yeah. And I just love to ask you a question about your workforce, because we're hearing that, obviously tons of nurses are leaving. I'm not so sure our doctors are leaving at the same rate, but nurses certainly seem to be. Are you tracking all those departures? Are you tracking the number of nurses in Vermont who are travelers within Vermont? Because one of our concerns is if travelers are a problem that are really forcing our hospital budgets to hemorrhage, why would we be funding traveling nurses to repay their loans and do loan forgiveness when they're gouging the system at the moment in a big way that's really unfair?
So the educational loan repayment program for nurses, traveling nurses, and per diem nurses are not eligible. So it does not fund them.
Even better.
And what I mean as far as ignoring our early pipeline is related to the AHEC work and the fact that we have had flat funding since 2006. This document that I gave you shows the pipeline of early pipeline, all of the type of activities we do for each segment of that pipeline. And there's just not enough funding or capacity related to the early piece of it as far as state investment related to healthcare development specifically. The other documents that you have show the framework for how we organize our work and the data that we use to inform it. This document shows the type of activities and objectives for each segment of the pipeline, whereas this one shows specific programs by name.
So I have one, thank you very much.
Yeah,
Very
that's been
helpful.
great.
I have one sort of loaded question, and that is, do you have any inkling as to why you were not called in to the House on this expansion of the program that you already get state dollars for?
I do not. I think it was just a big oversight.
I think it was
Is what I think that when we're a small organization, we do a lot. Please look at our materials for some of that data. We don't have a big, lobbying group. We don't spend our time here. We're really programming. I think when legislators and others think about educational debt and loans and scholarships, VSAC is the organization that comes to mind. But they're not the only ones involved. Can I just share one quick thing about VSAC? So with this new scholarship the state funded last year, we developed this really nice partnership with VSAC and how to administer that.
Which new scholarship?
For physicians or for medical students. It was state appropriated. It's funded for up to 10 scholarships to 3rd or 4th year medical students for future service obligation. And what we did is work with VSAC to leverage the expertise of the two different organizations. Our expertise in healthcare and medical student education, their expertise in administering loans. And each step of the way, we figured out who's best at this. And we have an agreement with them so that we're doing a big component of that work and helping with the longitudinal tracking. And we'll be the organization that figures out if this person returned to the state and is working where they said they would work in a county and the type of healthcare. That kind of partnership, I think, is really important as we look to future workforce initiatives.
Well, and critical that you're investing in the longitudinal study piece of it, because, we were just talking to Al in corrections, and they don't have the resources to do a longitudinal study to see if the things they have invested in have paid off in terms of people staying out of the system and having successful careers in the work they trained them in 20 years ago. So this piece is important.
We invested in developing our own database to allow for longitudinal tracking. We can create transcripts of individuals of, what the high school program they did with us, the undergraduate program. Now they're in the nursing workforce. Now they're in the medical workforce. We have that.
So, and we've done somewhat, I think, not right now, but love the tracking on where they're going if they're leaving here. Because that's what we're hearing is there's a big departure of nurses from Vermont, and either they're becoming travelers and leaving or they're just leaving. So that kind of
Thank you so much.
Thank you.
One question.
Let us have that, that'd be great.
One question you may want to think about at some point, and this is probably not so much for this session, is everybody has a problem about data analysis, about collection data, about longitudinal studies, about determining whether or not whatever it is they're doing is working as intended. And I wonder if that is something that one office or the statewide because of data collection data analysis might be much more efficient. Everybody's developing their own individual study. In many cases, they're fine. In other cases, they provide information that is not particularly of value.
Oh,
Especially,
yes.
especially in this area of workforce.
Yeah.
I'm becoming a believer.
I don't know how many studies, how many people are collecting data and collecting it differently around state government right now.
Yeah, we do. Good.
And actually, what I was learning about loan repayment programs in different places.
We take it, you'd say yes if we redirected the loan repayment administration and responsibility to you.
With one caveat, there must be administrative funding. We can't keep doing this by having to raise the
I
cost, but
assume,
yes.
I assume that the money that's not going to be set as an administrative budget piece.
I would assume so. Thanks so much.
So Gus, I'm
Wally.
really sorry. You understand the drill. We'll have you on Tuesday if you can make it.
I'll check the schedule with the,
Sometime next week. Yes, thank you very much.
We're sorry, Gus, but
okay,
Liz, thank you.
Thank you.
Thank you.
We know guys how often and how much you're doing something here, so.